Good evening. Good evening.
Good evening.
Thank you. I hope you can all hear me. I'm sorry we started late. I am Katile Utuku, and I'll be the moderator of the session, and I will be helped by Joshua Olio. I know we have interacted in the previous sessions, and today we'll be learning on fertility and premature menopause, a topic which I know many of you are expecting much from it, and I am very sure from our Dr.Lorraine Muluka, she'll take us through it, and you will learn more. So maybe, I don't, Dr. Muluka, are you in?
Yes, I'm in, Katile. Can you hear me?
Yeah, you're clear.
Okay.
Okay, thank you. So today's session is the session 5 of our training, and we'll be learning on fertility and premature menopause. And I know Dr. will introduce more about herself, and she will explain more about the topic. I know most of us don't know a lot about fertility issues with fertility, but people are experiencing it. And by the end of the session, I know we'll be having many questions and we'll learn more from it. So if there's nothing else, I think I can welcome Dr. Lorraine Muluka to say more about her and say more about the topic. So welcome, Dr.
Okay, good evening, everyone. I hope you can hear me. Kindly confirm if you can hear me.
Yeah, you're clear.
Okay, fine. I'm trying to share my screen, so maybe that will take a minute. But in the meantime, maybe I can introduce myself. My names are Dr. Lorraine Muluka. I'm an obstetrician, gynecologist. I am based in Nairobi at Upper Hill CAMedilynks, and also very passionate about ladies' health. And so I do share health posts on Instagram. My handle is at Obigaini. So you can also interact with me on that forum. Yes, so that's it about me. Katile, I'm having some technicality sharing the screen. I think it's because you are still sharing. Have you unshared yours?
Yes.
Okay, so let me try it once more. But yes, as Katile has said, we're going to be talking about fertility and premature menopause. Just a second. Kindly confirm to me when you're able to see my screen. Okay. And there we go. Anything on your end? Katile?
Not yet.
Okay. And right now, anything?
Yeah, it's clear.
It's now come through. Okay, great.
Yeah.
So yes, as Katile has said, we are going to be talking about fertility and premature menopause, and these are very important topics, especially to share with young ladies and men and anyone in the reproductive age group, basically, because at some point or the other, most people will be looking to start a family, get children. And so there are so many factors nowadays that people think about when we are thinking about when is it time to get pregnant. If I decide to delay my getting pregnant, especially for ladies, to when you have already started your career, will that then affect my fertility? So for this session, I actually asked some of the participants to send in their questions. And so I'm going to try and answer the questions as we continue with the presentation. But of course, if you have any questions at the end, then I'll still be able to answer those as well. I hope we are all on the same page. Kindly confirm, Katile. Or anyone else. Hello. Hello?
Yes, we are getting you, Dr.
Okay, fine,
Hello,
great.
yes.
And you're all seeing the screen, right? Okay, so I'll just...
Yeah, we are seeing the screen.
Perfect. So for this session,
Yes.
these are our objectives. We want to discuss about fertility. So we want to get a better understanding of what exactly does fertility mean? What are the factors that affect fertility? And then with that, we're going to get a brief overview on what ovulation is and what the fertility window is. And then we're going to look at what infertility is now on the other end of the spectrum, and what terms we use nowadays, because we're moving away from using the term infertility. We're introducing a new term called subfertility. So we'll talk about that. And then we're also going to talk about the different causes of infertility or subfertility, as it were, and how an overview of how they are managed. Yeah. Then finally, we'll touch on premature menopause. It's something that many people don't know about, and it's something that is quite important, because if it does happen to someone, then it could have a very significant effect. So we'll talk about the causes of that and the management. Okay. So what is fertility then? Fertility basically describes, or when you're talking about fertility, we're talking about the ability of a couple to be able to conceive naturally. So basically get pregnant without any artificial interventions. That's what fertility is. And so we have our first question from one of the participants who asked, what measures fertility? When a doctor says you're about 50% chance of getting pregnant, or you have a 25% chance of getting pregnant, what do they mean? So usually such terms are used when someone is trying to conceive, yeah? And normally we say when you're trying to conceive, the longer the period that you're trying to conceive, the higher the chances of actually successfully getting pregnant. So normally we start talking of at the time that you're starting to conceive, like the first month of trying to conceive, the chances are usually at about 30% to 40% to get pregnant. And this is depicted there. So about 30 to 40% chance in the first month of trying to get pregnant. And as we keep trying, as you can see, by the time you've been trying to get pregnant for about 1 year, then it's usually about 90% chance, okay? And this will be quite significant when we'll start talking about now where infertility comes in, okay? Now, we can't talk about fertility without discussing what ovulation is. And this was mentioned in the series about the menstrual cycle, but we'll just do a brief on it. And so ovulation is the time in a lady's cycle when the egg is released from the ovaries. So we have our ovaries here, and we have every month an egg being released. It goes through the fallopian tube and it stays in the reproductive tract for about 24 hours. That's a day, okay? And so for conception to occur, a sperm coming in through the vagina has to meet this egg within that time window, okay? So that's what ovulation basically is. And ovulation begins for ladies when you start experiencing your period. So this is usually at the time of puberty. That is when ladies start ovulating. And usually after some time, the ovulation, your cycles become regular, and that means that you're regularly ovulating. Eggs are coming out every month. So it's important to note that the highest time of getting pregnant, or chances of getting pregnant, usually are about 24 hours after you have ovulated, or 1 day before you ovulate, okay? Now, we have what we call before we get the fertility window, there's someone who asked, how do I know that I'm ovulating? Basically, how can a lady be able to tell that she's ovulating without going to the doctor? Are you able to establish for yourself that chances are maybe I am ovulating or maybe I'm not? So the body goes through several changes because of the hormones of the menstrual cycle. And so if a lady is ovulating, then there are these changes that she may see in her body. And so there's this image here of this lady, and you can see the different images on the side showing what are some of the things that you go through. So at different times of the month, right before you ovulate, you may notice that as a lady, you start having mood swings. 1 minute you're happy, the next minute you're extremely sad, almost depressed. You could be crying at almost nothing. And then there's also a feeling of heaviness in the breasts, or you may experience some pain on the breast, actually, if they're touched. There's some ladies at the time of ovulation, they experience some bleeding or some form of spotting, can have a heightened sense of smell. And then, so those are the physical signs that you are ovulating. Now, you can also be able to measure your body temperature. And for some people, when they're trying to track their ovulation, they actually get thermometers and try to measure their temperature every day so that you can be able to establish, is there a change in the temperature? And so usually at the time that ovulation has taken place, your temperature, the body temperature tends to go up slightly. They say by 0.2 degrees centigrade. So that is really a significant thing because it's something that shows that ovulation has taken place. Now, the other thing that can also be done is monitoring the change in the pattern of discharge that you're experiencing. Ladies tend to experience a discharge throughout the cycle from a different time. So some days you may be dry, other days you may have a discharge, but typically at the time that ovulation has taken place, then the discharge tends to increase. That's the first thing. And then the discharge also changes in its terms of its consistency. It becomes thicker and more slippery. So this is trying to show like a thick discharge. Usually describe it kind of like the thickness of an egg white. So that kind of thickness is what you'd experience. Then there's also ladies who experience cramping, usually at the time of ovulation, okay? So from there, I hope we're all together. Confirm to me if I'm moving too fast.
We are together.
Okay, great, thank you. So from there, we're going to now get into what we call our fertile window. Now, once we've understood what ovulation is, there's what we call the fertile window. And this is usually frequently seen with the pregnancy apps or the period tracking apps. You get an app and you'll see that it usually shows you different color codes, and there's usually a certain point where it says, this is your fertile window. So depending on what you're using the app for, sometimes you could be using it because you don't want to get pregnant, so you don't want to have sex during the time of fertility, or you could be using the app because you are trying to get pregnant. So you want to maximize maybe having intimacy on those days. So usually the fertile window is a 6-day period, and it usually includes the day of ovulation. Now we have an image here that's just one of those calendars that are in the apps. And so what you'll notice is that here they mentioned that the last menstrual period was on the 2nd of December, which was a Tuesday, and the cycle was 28 days, okay? So normally you get, we usually ovulate around the mid of your cycle, yeah? But the most important thing that we usually, so for us to be able to tell when you're ovulating, or what these apps use to be able to tell when you ovulate, is your cycle length, okay? So if your cycle length, they have it established is 28 days, it means that you bleed on the 28th day. And normally ovulation happens 14 days before you get your menstrual period, okay? And when we're discussing the menstrual cycle, we realize that different ladies have different cycle lengths. So you can have cycle lengths ranging from, for a normal cycle, between 21 days to 35 days. So if you fall among the people where your period comes in after 28 days, then that means you ovulate on the 14th day. And so your ovulation, your fertile window rather, is going to be that 14th day and the 5 days before that. However, if you're a lady who has a period that is shorter, like you have a period, a cycle rather, that is 21 days, then that means that you ovulate on the 7th day of your cycle, okay? So for such a lady, your fertile window will then actually be that 7th day of your cycle and the 5 days that are before that. So it's quite important to know that. So so there was a question about the fertile window. Someone asked, can I get pregnant a day before my fertile window? And can I get pregnant 2 days after my fertile window? And the answer to this is yes, okay? When we use the fertile window, we are assuming that the period is going to come exactly at 28 days, exactly at 21 days. But sometimes you'll notice that there are usually some changes in the time that you get your period. So instead of it coming at 28 days, it may come at 26 days. Instead of it coming at 28 days, it may come at 30 days. And that means that you probably did not ovulate on the 14th day, you ovulated on the 16th day, or you ovulated a bit earlier. So yes, you can get pregnant still. So that is why even when you're using this app to prevent yourself from getting pregnancy, in some cases, you may still get pregnant outside the fertile window. Now, the next one was, at what age is a woman most fertile? Okay, so to answer that, we have this image that generally shows what a female fertility timeline looks like. So the one thing to know is that ladies are born with all the eggs that they are going to have. So they're usually millions of them. And you can see from the far left, it's an orange, it looks like an orange. It's quite orange. And as you continue going towards the right, you're seeing infiltration with white. So basically what is this trying to show is that as we continue aging, as ladies continue getting older, then the number of eggs that you have keep diminishing over time. So some of them you will get ovulated, they'll come out as a period, but while they're inside the ovaries, there are those which will just die naturally while they're there. Now the rate at which, or the speed at which they die, increases as you get older. So to answer the question at what age is a lady most fertile, from this you can see that basically between 18 to 24 is the best age to get pregnant. You're most fertile at that age, but still, as long as you're below 30, the chances of getting pregnant without any interventions are pretty good. And all the way up to 35, yeah? Now, once we get past 35, then we start having a significant reduction in fertility. And we also start having issues in terms of conceiving, because also not only the number of the eggs is going down, but also the quality of the eggs that you have is also going down. So by the time a lady is getting to 41 to 45 years and above, the body is basically preparing for menopause. So usually at this point, fertility has significantly reduced. Yeah. So we're going to talk about factors that affect fertility. And we've already mentioned the first one, which is age. So an increase in age is actually directly proportional to a decrease in fertility. And this timing of intercourse. We've talked about the fertile window, but we don't really emphasize on people trying to, to aim for to get pregnant during the fertile window. Like, you're just always counting down. Basically, what we advise is that if you're having regular intercourse, because most people do not even usually know what is your fertile window. Some babies just tend to come in, yeah? So usually as long as you're having regular sex 2 to 3 times a week, most of the time people will get pregnant. But timing of intercourse becomes a factor affecting fertility if a couple maybe is not staying together, maybe they only meet once a month, then, at that point, if you're trying to conceive, then it's significant to be able to time the intercourse during the time that you're most fertile. Then there's issues of weight. If you are at either extreme, if you're either obese or you're extremely underweight, then that can also affect fertility, because you tend to see that in such ladies, most of the time they're not actually ovulating, and they also tend to have irregular periods or absence of periods. Then the other factor is smoking. Smoking in both men and women affects the quality and also the number so in ladies, it affects the quality of the eggs and the number of eggs. So it's a factor that can cause you to have decreased fertility in that way. For men, it reduces the quality of the sperm. And then for ladies, there's an increase in caffeine intake. It's been shown to, if you're taking a lot of caffeine, more than 200 milligrams a day, so say about 2 cups per day, then you could be at an increased risk of having reduced fertility. Same with excessive alcohol intake. And for excessive exercise, this is mainly on the end of like athletes, people who are really doing exercise for their competitiveness. So you tend to notice that such ladies, again, tend not to ovulate, yeah? And so we tend to see that they have issues with fertility at the time that they're trying to conceive. But this is usually something that is short-lived. Usually at the point when you stop having the excessive exercise, then there's usually a return to fertility. There's issue with also eating disorders. So if someone is having eating disorders such as bulimia, anorexia. This also affects your hormones, which are usually produced to help with ovulation. And so you can have that affecting your fertility. For drugs, the main drugs that are usually toxic for fertility are drugs that sometimes are used in treatment of cancers. So those are the main ones that usually we see affecting ladies' fertilities. So now we move on to talking about infertility. And we have already understood what fertility is and the factors that can affect that. So when we talk about infertility, we're talking about a couple. It's significant for us to note that it's both the lady and the man that we're talking about. When you've been trying to conceive for a period of 12 months, not using any family planning methods, having regular intercourse, as we've said, about 2 to 3 times per week, but you're not being able to conceive. So the term infertility is a traditional term that has been there for the longest time. But we are now moving away from that. We're trying to talk more of subfertility, because infertility comes with the stigma that you can never ever be able to get pregnant. And it's actually been shown that in about half of the people who have been diagnosed with infertility, that's failure to conceive after 1 year, in about half of them, without doing very extensive treatment, maybe just giving them advice, we're able to see that they get pregnant. So we're moving away from the term infertility and talking more subfertility. But still, you will encounter the term, you'll even encounter that in the clinic, you're being booked for an infertility clinic. So we're still basically gravitating towards subfertility. So what is primary infertility? Because there are different types, 2 different types of infertility, and it's significant to know the difference. So primary infertility means that there's never been conception. A couple has never ever been able to conceive, okay? Now, with secondary infertility, we're talking about a couple that has ever conceived, but they are now trying again to conceive and it's not happening, okay? So basically, if you've ever conceived, even if the pregnancy ended in a miscarriage, so there's no baby or there's no child to show that conception ever took place, but it did happen, that falls under secondary infertility. And also people who had children previously tried to conceive again, then that also falls under secondary infertility. So what are the causes of infertility? So these are the main causes of infertility. And we've already talked about ovulation and how that occurs. So in some cases, there's some ladies who are not able to ovulate, yeah? So if you're not able to ovulate, that means the egg does not come out. And so even if you're having the regular sex, you're not using any contraceptives, there's no egg for the sperm to meet, okay? And then there's also damage to the fallopian tubes. Normally, this is the passage for the egg to come down, for the sperm to meet it. So if there's a blockage in these tubes, in this basically tunnel where they're supposed to meet, then you can have issues with fertility. And so we have endometriosis. We had a talk on endometriosis recently, and there's a mention of fertility. And so basically endometriosis has several ways in which it can bring about reduced fertility, basically inflammation, but also significantly it can cause blockages inside the tubes, which now sometimes prevent the sperm and the egg from meeting. Then there are also male factors that are associated with infertility, yeah? And in some cases we find unexplained infertility. Basically, we have done tests and we're still, as the doctors, we're not able to find the cause as to why the couple is not able to conceive. Now, the other causes of infertility are things like fibroids. So sometimes we find that there can be an association with infertility when you have fibroids, especially if they're seated inside the uterus. And then also if there's issues with, when we talk about coital problems, we're talking about issues with having sex. So basically it could be maybe an erectile dysfunction for the man, or maybe something to do with premature ejaculation, or maybe on the lady's end, she could be having abnormal contractions at the time of sex, making it very difficult for that to take place. So those are some of the issues that are there. Other issues are people using some of these lubes, the lubricants that may have spermicides. So you're trying to have sex and trying to conceive, but part of what you are using is actually killing all the sperm before it gets a chance to get to the egg. So it's very important to, put all that into perspective, even at the time that one is trying to conceive. Hello? Are we together?
Yes. We are following.
Okay, great. So next is this is just to show a reflection of where we are, or how these factors contribute to reduced fertility. And you can see that for the female infertility factors, they carry about 37% of the factors associated with reduced fertility. And for male, on their own, about 8%. Now, significantly, we've noticed that both male and female factors, that means that the man and the lady, both of them in the couple having an issue that is contributing to reduced fertility, is in 35% of the couples. So that is quite significant. And this is why when we're talking about treatment, we always want the couple to come together, because you don't want to start just by examining the lady and trying to find issues in the lady alone. You could find an issue or not find an issue, but sometimes even if you find an issue in the lady, but you haven't assessed the man, you have not done the couple justice, okay? So for investigations as for fertility, when do we want to start them? Sometimes patients come into clinic, we see them and they're like, Daktari, I've been trying to get pregnant for 3 months and nothing is happening. They're very worried because, most people imagine that the moment I decide to get pregnant, I will get pregnant immediately. So this is when we remind ourselves of the previous slide that showed us how long it takes to get pregnant. The percentages, we said in the first month, it's about 30 to 40%. And by the time you get to 1 year, then 90% chance of having gotten pregnant. So for most ladies who are below the age of 35 and who don't have anything alarming in their history, we usually wait for the 1 year mark, 12 months to go by before we start investigations. However, there's some cases that you may want to investigate a bit earlier. So this is what the table is showing us here. So basically, ladies who do not have regular periods. So by regular period, we need to understand what that means. A regular period, we tend to say by and large a period that comes in every month, first of all, and it takes roughly about the same time. So if it doesn't have to be exactly 28 days, it could come in maybe 2 or 3 days earlier, 2 or 3 days later. But if a period is fluctuating by more than, like this month, it's 28 days. The next month, it's taking 35 days. The next month, it's coming in at 20 days. That is an irregular cycle, okay? Or now, on the other hand, if you're having periods coming in after every 35 days, that is actually also another irregular cycle. So those are ladies who you want to investigate even before 1 year has lapsed, because there's already an issue that's displaying itself, okay? If a lady has had a history of a prior ectopic pregnancy, and an ectopic pregnancy is a pregnancy that's occurring in the tubes, then that is a lady that you want to investigate earlier, because we have 2 fallopian tubes. And commonly when we manage ectopic pregnancies surgically, what we do is we end up taking out the tube in which that pregnancy had implanted inside. So these are ladies who are left with only 1 fallopian tube. So if she's been trying to conceive maybe for about 6 months and nothing is happening, that is a lady that you may want to investigate earlier. Any lady who's had any previous surgeries in her abdomen, maybe an appendix removed, or maybe she had an ovarian cyst removed earlier, and she's trying to conceive and not getting pregnant within 6 months, we'd want to investigate her as well. As anyone who has had a history of sexually transmitted infection or pelvic inflammatory disease. So usually the sexually transmitted infections that commonly would cause PID that can affect your fertility are chlamydia and gonorrhea. So we usually want to evaluate these ladies because those are diseases that have been shown to actually affect ladies' tubes. And how they do that is they cause inflammation inside the tube, basically, and they end up causing some blockages in the tubes. So I think those are questions that someone asked, if there is any way to prevent you getting infertile. And so one of the ways that comes up is early treatment of suspected STIs. So if someone has symptoms that are in keeping or look like an STI, then we always advocate for early treatment for that. Then as well as history of someone being treated for cancer with chemotherapy or radiotherapy that exposed the pelvis or the ovaries, then we usually want such a person to also be evaluated earlier. For men, if they've also ever had any surgeries in their urinary tract, in their genitals, mostly we hear of men having either undescended testes, and so maybe they had to have a surgery for that, or maybe they had an issue with the testes. Sometimes the tubes tend to go around themselves, what we call testicular torsion. Then usually we want to assess such a man earlier. And also infections such as mumps in adulthood have been shown to affect men's testicles. They actually get what's called otitis, which is inflammation inside the testicles. So those are people who we want to also assess earlier. Now, with that said, then we want to talk about what is it that we are looking for when we are investigating. What is our goal? Because you have to investigate with a goal in mind. So basically for the ladies, you want to establish a couple of things. We're looking to find what the causes are and to come up with a plan of management. And so for a lady, you want to find out, is she ovulating? And if she's not ovulating, why not? Okay. And then you can be able to then take the next step from there. And then the next thing you want to find out is there any tubal disease? Basically, does she have damaged tubes? Are the tubes blocked? So that we can also be able to take that step from there. And then there's what we call the ovarian reserve. And this is basically what I talked about earlier. Basically the number of eggs that a lady has. We want to find out what is that like? What is the current number of functional eggs that she still has, okay? And then we also want to establish if there are any abnormalities in the uterus that could be causing an issue with her fertility. For the men, we want to find out if they're having any sperm in the ejaculate, and if there's no sperm in the ejaculate, why is that happening? And we also want to find out if there's sperm, does this sperm meet the criteria for what we call normal sperm? Because sperm is supposed to look a certain way, it's supposed to move in a certain way, it's supposed to be in a certain environment that is healthy for it. So those are some of the things that we look at when we are assessing the male factor. So what tests do we run? So normally to find out if a lady is ovulating, we want to, there are two things that we can basically do. When we talked about the menstrual cycle, there's a different way that the hormones change in the course of the cycle. And so usually once a lady has ovulated, the most important hormone, ovulation takes place with a hormone called luteinizing hormone. And after that, the next important hormone that starts being produced in the menstrual cycle is called progesterone. So usually we want to test this hormone in the second half of the cycle to see, is it an appropriate level to show us that ovulation has taken place. Now, the other thing that can be done is by ultrasound. And this is just an image showing us what an ovary looks like. This white here is the white kind of circular ovoid thing is the ovary. But what basically you look at with the ultrasound, you have to do daily follow-up ultrasounds looking at these follicles, and the follicles are the slightly pink parts, and you follow them trying to see a follicle growing all the way to the point whereby it will disappear. And that's when we know that ovulation has taken place. Okay, so this one's a bit more cumbersome. because it definitely involves more input, yeah. And then to establish what a lady's ovarian reserve is, or what the number of eggs she has, these are hormonal tests that we carry out. The two that are done, there's one that's called the anti-Mullerian hormone, and there's also the follicular stimulating hormone. So they need to be at certain levels. So we look at the levels to see whether you actually are having adequate eggs remaining in the ovaries, okay? The other thing that can also be done is counting of those follicles that are shown in the previous slide using a transvaginal scan, just trying to see whether they are adequate again in number. Now, so from there, we are now able to move on to the second part of our assessment, which usually involves looking at the conduit, which is the passage for the egg. So once the egg, if someone is ovulating, you want to see, is the road open for this egg to come into contact with the sperm, okay? So normally, the test that we commonly do is what we call the HSG, okay? And this tubal factor in our setting is actually one of the #1 causes of female infertility. So usually this is a test that is commonly done for ladies who come in with delayed ability to conceive. And how it's done is a dye is introduced through the vagina into your uterus, and we want to see the route that this dye will follow. So basically from down here, the vagina, it goes up into the uterus, it fills the uterus, and we want to see the outline of the tubes and eventually see the dye coming out into the abdomen. That is the goal of the test. So if we're able to see that taking place, because that would be ideally the route that the sperm also follows, then that means that these tubes are open. And that is what we are seeing in the first one that's labeled normal. Now, the HSG, besides just showing us the uterus and the tubes, it can also be able to pick up if there's a problem in the uterus itself, yeah? So like in the second one, we're able to see that the dye goes in, but at some point, there's some form of blockage, this black thing at the top, and the dye stops moving. So at this point, we can tell this is a lady who had a fibroid, which was sitting right at the top of the uterus, and it was preventing basically dye going through, and also possibly could prevent sperm from getting to the egg. So in the last one that's labeled the hydrosalpinx, we can see some sausage-like structures at the end. So we're seeing the dye goes in, but once it gets to the end, we're not seeing it spilling out into the abdomen like in the first image. It's kind of collecting together at the far ends. And so this is usually a sign of tubal disease, basically tubes that have gotten scarred because they maybe got an infection. And so usually we tend to see that the dye, if the dye cannot come out through here, then that means that even the egg cannot be able to get into the tubes at the time of ovulation, okay? So this is just an image showing basically what we're talking about when we talk about the tubes being scarred or the tubes having adhesions. We can see these white bands, the white bands that are in there. You can imagine like when you have a cut or you have an injury on your hand and you form a scar. So it's basically the same thing happening, but now inside the tubes. And so when that happens, then you can see at this point, this is the ovary. If an egg were to be released, there's so many points where it's being blocked, so it would not be able to get to the final destination, okay? So another test that we usually carry out just to see the anatomy basically of the uterus, if there's any abnormality, is usually a pelvic ultrasound. And usually that looks at both the uterus and the ovaries. And in this image, it's just showing basically some of the things that an ultrasound can be able to pick up. Can be able to see fibroids at different places, and significantly this one that's right here, the middle, the intracavitary one. If a fibroid is seated in this position, then this is one that can be associated with reduced fertility. Or if a fibroid is blocking all the way at the top here, then that can also cause a lady not to be able to conceive because the pathway is blocked. Now, other than those tests, there are other hormonal tests that we do. The ones we spoke about are about checking for ovulation and about checking for basically the ovarian reserve, what eggs she has in her ovaries. Now, the other hormonal tests, these were mentioned when we're talking about the menstrual cycle and how they affect the cycle. And so these hormones, we usually test them, the follicular stimulating hormone, luteinizing hormone, and estradiol. Those three are part of the menstrual cycle, and we want to see what their levels are, okay? Because sometimes people use a term called hormonal imbalance, but basically the hormones that they're talking about that could be causing a lady to be getting irregular periods and maybe not getting pregnant could be one of those hormones. Significantly, there's two other hormones there, prolactin and the thyroid stimulating hormone. Prolactin is a hormone that's produced in the brain, and normally it goes up in ladies who are breastfeeding. But sometimes you can have abnormal production of this hormone in a setup where you're not breastfeeding, but it just really goes up. And often there could be maybe a swelling in the brain that's causing that hormone to go up. And when that happens, then that can affect a lady's fertility, and she would notice that there would be a change in her menstrual cycle. Then there's also the thyroid stimulating hormone. The thyroid gland sits at the front of the neck, and usually it produces this hormone, which helps regulating also part of our reproductive hormones. So if this hormone is also not being produced well, then usually you could get an issue with fertility. So this is basically the full spectrum of tests that we do in a lady who presents with inability to conceive within 1 year, okay? Just checking that we're together once again.
Yes.
We're good, and I hope the speed is okay for everyone. Okay. So we're going to now switch gears and talk a bit about male infertility. There are not so many questions on this, but it's just important to mention it because it's something that is there. As you saw, it contributes to about 8% of cases, and 35% of the time we find both the man and the woman has an issue. So it's significant just to mention it, right? And so for the male infertility, what's the first thing to note is that men produce sperm, new sperm, every 90 days. Unlike a lady who is born with all the eggs that she will have and they continue dying off at a specific rate over the years till the point when the eggs will end, what we call menopause, men are able to produce sperm every 90 days. However, as they also age, the quality of the sperm starts changing, okay? So they're not at their very best. So even for men, as they are younger, then obviously they have then better quality sperms. So for male infertility, usually it's problems that result in either abnormal sperms or reduced or absence of sperms in the ejaculate. So either there's a problem at the level where they're being produced, which is usually in the testicle, okay? So the sperm is produced in the testicle, and it is then transported all the way, so via what we call this tube called the vas deferens from the epididymis, then something seated right on top of the testicle called the epididymis, and that's this tube now, the vas deferens now picks that sperm from there and takes it all the way to the urethra. And on the way, there are usually different glands which give some fluids to kind of give the sperm some nutrients as they are on their way. And so that's where the seminal vesicles, the prostate comes in. And then the sperm comes out from the urethra, this tube, during ejaculation. So when we're assessing for male infertility, we're trying to see, is there an issue at the level of production? Maybe the sperm is not being produced, or could there be an issue with this transport system? Because as you can see, it's a tube, there could be blockage at some point in the tube. So that's what we usually want to find out. So for men, again, the production of the sperm at the level of the testis is under a hormonal influence. So the hormones that are usually tested are the follicular stimulating hormone and the luteinizing hormone, which are produced in the brain. and then testosterone, which is produced now at the level of the testis, okay? And then we usually run a test called a semen analysis. And basically what we do is take a sample of the ejaculate, and it's then looked at in the lab to determine whether we have, what number of sperm do we have in there, and how do they look? Are they normal? Are they moving? Are they dead? And so we're able to now pick up if there are any abnormalities. In some cases, when we find abnormalities, then we may send a man to do what we call a scrotal ultrasound or a testicular ultrasound, just to be able to now look at more of the system in detail to see whether there's a problem or a blockage inside the system. So often we tend to work with urologists, especially when it comes to male infertility. But this is what you'd expect in terms of tests that are done for the men. So for treatment, this is what we say: we treat the cause. Okay, so we ran the test, we looked at the objective as to why we're running the test. So for the ladies, if you find that she's not ovulating, you need to find the cause of why she's not ovulating. There are several reasons why she may not be ovulating. Some of those last hormones that we put up there could be the cause. Commonly, we have a condition called polycystic ovarian syndrome that can be picked up usually from the ultrasound and just the symptoms that the lady is having. So if you find the issue is ovulation, then you treat that, and then you see whether she'll be able to get pregnant. Now, the other thing is about the tubal disease. If we find that there's tubal disease, we need to see to what degree do we have tubal disease. In some cases, there's some which can be able to be surgically corrected, but in some other cases, if you cannot be able to do surgery, then we usually offer them what we call assisted reproductive techniques. Maybe you've heard of the IVF techniques. We usually refer you to a fertility specialist, and then they'd be able to carry out those methods of treatment. Yeah, and then if it's something with the uterus, like let's say we find there's an abnormality, we find that it's a fibroid, we find that maybe there's a growth inside the uterus called a polyp, we then take those out. Sometimes we find that the uterus has an anatomical issue, it doesn't look like a normal uterus, and so those ones can also be surgically corrected. And then for the men, as I mentioned, we treat the cause together with the urologist. So for the men, significantly, because they produce new sperm every 90 days, then we usually want to run a second semen analysis after another 3 months, so that we can be able to compare the two and see, is this picture still tallying, or is it just a one-off at the time that the first semen analysis was taken, that it was abnormal. So it's not something that would be peculiar if someone is told, okay, you already did a semen analysis, but we need to repeat another one after 90 days. So that's what we had on basically on fertility. And now I think we'll just move on to premature menopause if it's agreeable with everyone, and then we can have questions at the end. Is that fine?
Yes, that is okay.
All right, great.
Yes.
Thank you. So we're going to mention premature menopause, and this is a topic that actually ties closely with fertility because it's basically menopause occurring at a time in a lady's life when she was not prepared for it. So as we spoke about this earlier, ladies are born with a finite number of eggs. So basically, throughout a lady's lifetime, the eggs, some of them she will ovulate them, some of them will just naturally die off. Now, menopause is usually a stage in a lady's life when she stops experiencing menstruation. Basically, she stops seeing her periods. And normally we make this diagnosis after a lady has not had periods for 1 year. So what is premature menopause then? Premature menopause is basically this occurring before the age of 40 years, okay? And normally menopause occurs usually about at the age of 50 to 53 years. By By 55 years, most women have already experienced menopause, but the average age is usually about 51 years. So you can imagine a lady who is, because we're saying before 40 years, so she's probably in her 30s, and maybe at that point is when your career is just taking off and you have been delaying getting pregnant because you've been trying to build your career and maybe you are thinking to get pregnant later, and then menopause happens. So this is something that's really significant because it can have a lot of effects, both emotionally, mentally, and as well as physically, because going through menopause is it's difficult. So just the natural menopause is difficult, but a premature menopause is now a whole different ordeal. So what are the symptoms of premature menopause? And what exactly is going on when this premature menopause is happening? So basically what is happening is that this lady no longer has eggs to produce the reproductive hormone estrogen. So what she then experiences is symptoms of lack of estrogen, okay? And this is what women who undergo menopause usually experience. So they get hot flashes, which are usually just sudden heat waves that appear all over the body, and you're sweating uncontrollably. Often people describe the sweat being worse at night. And then there's also issues with your memory. People start forgetting things, you get more forgetful, people get a more moodiness, so you're very irritable. Some people even get a lot of anxiety and mild depression. So you can see where the mental health is checking in. And then there's also a lot of changes in terms of sexual health, because one is a decrease in libido, so the sex drive goes down. And then two, sex is painful. Sex is painful because the vagina is dry, because estrogen is an important hormone that helps with lubricating the vagina. So all this plays in, and then there's also weight gain, there's also hair loss. So you can see this is a lot to deal with, and we need to keep in mind that this person going through this is below the age of 40 and was not expecting any of this to happen, okay? So one of the participants asked what causes premature menopause. So there are a number of risk factors or causes of premature menopause. Some of them could be as part of a treatment. So ladies sometimes may have what we call, you may have ovarian cysts, or maybe you can have an ovarian growth and it has to be taken out during surgery. And sometimes the ovary has to come out with that growth. And so that is a surgically induced menopause, okay? Now, other things that can be risk factors to premature menopause are things like smoking. We already spoke about the effect of smoking on the quality and also the quantity of the eggs that a lady has. And so in some people, we've seen ladies who excessively smoke, then they've been seen to be the ones who sometimes fall into this group that gets a premature menopause. And then there's also having surgery to remove the uterus, what's called the hysterectomy. So even if only the uterus is removed, but the ovaries are left behind, there's usually an element of loss of blood supply to the ovaries, because some of the blood supply comes from the uterus itself. And so in such cases, we see that some of these ladies then undergo this premature menopause. Then we had mentioned as a side effect to treatment for cancer, what we call chemotherapy or radiotherapy. So sometimes these drugs are quite toxic to the ovaries, and so we see that these ladies then don't end up having premature menopause. Then a significant thing is if you've had a family member who has experienced menopause at an early age. And so this goes for your mother or your sisters significantly if they've had menopause, because menopause tends to follow a family pattern. So if some of the members had menopause at an early age, so it would be important to maybe find out if you have an older sister and has gone through menopause, at what age did that happen? Mother as well, you can find out at what age did that happen, okay? Then there are also some medical conditions which are associated with premature menopause, and significantly what we call autoimmune diseases. Autoimmune diseases are basically we have an immune system which is there to protect us from foreign, basically from anything that is foreign to our body. So what happens when you are affected by something foreign, like a bacteria, a virus? This immune system detects that this is something foreign and it mounts a response against it. Now, sometimes, unfortunately, this system malfunctions. And so what happens is that your immune system starts detecting your own body as something foreign. And so these substances, usually called antibodies, that it's supposed to use to mount a response to fight something foreign, are now fighting you. And so in these cases, you can see that now some of these cells now mount a response against cells in the ovaries. And so we significantly see a decline in now ovarian function and then premature menopause. So there's also certain infections that have been associated with getting premature menopause. Things like mumps, again, has been shown to cause inflammation at the level of the ovary. And so that has also led to ladies having premature menopause. Okay. So there's someone who asked on how one can prevent premature menopause. And so that will just, we'll take that back to this slide. And so the modifiable risk factors, what you can actually do to maybe prevent that would be, if you're someone who smokes, you'd want to then avoid the smoking from the surgical end of view. For the surgeons, the doctors who deal with patients, we always try to, even if it's a surgery that we have to remove part of the ovary, we still leave someone with part of the ovarian tissue. So that can really help in avoiding to get the premature menopause. But really, by and large, there's nothing much that can be done to prevent it, okay? I think there was also, let's see. Can premature menopause cause health problems? And the answer to that is yes, because estrogen is a very good hormone, yeah? So once you go into menopause, then there's certain health problems that have been associated with that. And so usually estrogen has been shown to protect the bones, it's been shown to protect the heart. And so at this point, when now you go into premature menopause, there's risk of getting what we call osteoporosis, which basically is like weak bones, which can easily fracture. And then there's risk of getting heart disease, then mood disorders, which are things like anxiety, depression. Then there's also sexual dysfunction that we've talked about. And in some studies, it's been shown that women who've gone through premature menopause are just at risk of having an earlier death, and also other brain-related diseases such as dementia, okay? So how do we then diagnose premature menopause? So basically, it all comes from the history. And if the history fits, if someone comes in and says, my periods have just disappeared, and then we do some tests and we find that we confirm that this lady does not have, the level of estrogen hormone is down. And then we usually also test the other hormones, which we talked about in the menstrual cycle, the follicular stimulating hormone and the luteinizing hormone. If we test those and we see that those are significantly elevated, then we usually make a diagnosis of premature menopause, okay? Now, tying this together with fertility, because these ladies who then would ask, what can you do in terms of treatment? So usually for treatment, mainly what we do is we give hormone replacement therapy, but that would just help with treating the symptoms. That would not do anything for fertility. So in terms of fertility and premature menopause, when we're thinking about options for such ladies, there's usually, if it's someone who's going to have, for example, the chemotherapy, the radiotherapy, they're usually options of maybe freezing the eggs prior to you undergoing that kind of therapy, because now we understand that if you're having radiotherapy or chemotherapy, then there's a risk that you could undergo premature menopause. So those are still part of now what fertility specialists do. So it would be prudent to visit a fertility specialist if maybe one has been diagnosed with a condition that requires that kind of therapy. And then also in terms of fertility, the other options is that, again, they can be given assisted reproductive techniques whereby you get what we call donor eggs. So basically someone else donates an egg and that can be used for you to get pregnant with. So when I speak about hormonal replacement therapy as treatment for premature menopause, what we mainly replace are the estrogen and progesterone hormones so that we can try and control these symptoms that come in with premature menopause. And the final question, I think, was, is there a possibility of a woman who has attained menopause getting pregnant? And the answer to this is no. If a lady has actually attained menopause, that means you have met the criteria of going 12 months without getting a period. And we know that it's not due to a medical condition or due to any medication that you're taking. Then usually menopause is a point whereby the number of eggs that you were born with are completely diminished. So usually no, there is no point at which you've seen someone getting pregnant spontaneously after menopause. However, because of fertility techniques that are there, as I've mentioned, the donor eggs and the capability of being able to freeze eggs previously, someone who has then undergone menopause can use the assisted reproductive techniques to still be able to carry a pregnancy, but that would not be a natural conception. So I think I'm going to end there. And thank you all, everyone who has joined in. And so I think I'll ask if we have any questions at this point in time. We could be able to, ask them. Hello? Have they been typed in the, anyone has been keeping a record of the questions? Okay, I can see one from Josephine. Sorry.
Hello.
Yes, hello.
I see some questions in the chat box.
Okay.
So maybe I can read them. Yeah.
Yes, maybe you can. Let me see. Yeah, there's several. Okay, so here we go. Hi, I used to know menopause starts at 45. Did it increase by time? That is from Josephine. Okay, yes. For menopause, the median age is usually 50 years, okay? But normally it can occur even earlier than 50 years, but anything that occurs before 40 years, that is what we use as a time to say that it's premature menopause, but not 45. So from 45, if it happens after 40 years, it doesn't really count as premature menopause, but normally the median age, when you look at a population and you look at the age at which most ladies will get into menopause, it's usually 50 years. So I hope that answers that. And then let's see. Someone has asked, you talked about scarred tubes that block the passage of the ovum. Can that be treated? And if yes, how? Also, are there any symptoms for tubular infections? That's a good question, Wendy. So when we talk about the tube scarring, basically it can happen from different things, yeah? So it could happen from surgery. Maybe someone has undergone a surgery, and because of the healing that takes place after the surgery, you find that the tubes are getting scarred. Someone could have also had an infection. So normally those are the the silent culprits, unfortunately, because the STIs may sometimes not present with any symptoms, and so you don't know that you actually have an infection. But for treatment of the blockage of the tubes, it depends on the level of blockage and how severe the tubal disease is. So if it's something that is blocked, usually towards the end of the tubes, what we call the fimbria, those are usually easier to then open up. Okay, and that can be done during surgery, and usually that is minimal access surgery, laparoscopy. So let me see. Now, do we really have safe days? Well, yes, I'd say yes, we have safe days. So as we mentioned, ovulation, from the time that you actually ovulate and the egg is can be fertilized, it's 24 hours. So you can imagine the rest of the cycle technically is safe. Okay, but normally, because we want to be extremely safe, if you're using the natural method to track your cycle, then you'd want to then really make note of what your fertile window is. Because if you know when your fertile window is, then you're able to avoid having sex on those days, and the other days of your cycle would then be your safe days. So the question has just come in is, can irregular periods 35 days cause infertility? So a normal cycle usually is from 21 to 35 days, okay? So if you have a cycle that is above 35 days, then usually the first thing that we start thinking is that likely you are not ovulating regularly. So that would be something that would be significant to get checked, because if someone is not ovulating regularly, then they could then have difficulty in trying to conceive. That's not saying that they don't ovulate in all their cycles. There's some cycles that you may ovulate, there are others that you may not. But if you're having a cycle that is actually above 35 days, then that would mean that you need to be assessed, okay? Kindly clarify, can you have your periods if you are barren? Okay, thank you for that question, Ivana. So we don't usually use the word barren, but I think we're talking of the same thing, basically. Basically, if you are subfertile or infertile, and yes, you can get your period, because when you get your period, I think this was mentioned briefly in the menstrual cycle talk, but when you get your period, what you're actually seeing coming out as a period is a result of you not getting pregnant, right? So there's two things that are important to note. There's usually the egg that ovulates, comes out. If it doesn't meet a sperm, then that would then come out. And also, if there's usually the lining of the uterus. So inside the uterus, actually preparing throughout the months, building up in case one gets pregnant. And if you don't get pregnant, then that is also shed out together with the egg. So normally, someone who is not fertile, someone who is infertile rather, or having an issue with fertility, can still get periods, and they can actually get those periods every month. Just depends on where the issue is, okay? Now, what normally happens to those women who get pregnancy and have passed menopause? Good question, Atola. So what happens is, it's about the diagnosis of menopause, okay? Menopause is when you have stayed 12 months without having a period. And we have confirmed that this is not due to any medical disorder or due to you having any use of any drugs. That, you know, sometimes you can be on a contraceptive and you don't get your period for 12 months. That's normal, because we know the reason is because you're on a contraceptive. But if you actually do meet the criteria of menopause, that you have gone 12 months, that's a whole year, without getting a period, then it is not likely to get pregnant. So likely this person who said that they had reached menopause, because, you know, menopause is also a thing that ladies assume in their head sometimes, that I've reached menopause, miaka yangu ni ya menopause, so I can't get pregnant. But maybe at that point they were in the premenopausal error whereby maybe they've gone about 5 months, 6 months without seeing a period, and they assumed that they had reached menopause, but then at some point there's still some eggs that come out. And that's why we really mention until you reach menopause, if you're not keen on getting pregnant, it's important to embrace a method of contraceptive because there is still a possibility of getting pregnant, okay? Now, someone has asked, if you don't get periods, can you get pregnant? Now, Jacinta, thank you for that question. If you don't get periods, that tells us that there is an issue because periods are the sign of ovulation taking place, right? So if you're not getting periods, then we need to know why is it that you're not getting periods. So to say that you can't get pregnant would not be correct because there's some ladies who sometimes do not ovulate, commonly women who have polycystic ovarian syndrome, and sometimes they just spontaneously get pregnant because they could have ovulated without having seen a period and they get pregnant. So you can get pregnant even if you've not been seeing your period. And then again, there's some women who are breastfeeding and so they don't see their periods and again, they can get pregnant. So yes, can contraceptives cause infertility? Judy Risper. No, contraceptives cannot cause infertility. Usually most of the contraceptives, the moment you stop using them, then your fertility immediately returns within a month or 3 months. However, with the use of the injectable contraceptives, that's a depot contraceptive, that's a one contraceptive that has been shown that it can delay return of fertility in some women. And there's some studies that have actually shown that the moment you stop using the depot injection, sometimes you can actually stay even up to 1 to 2 years. Very rare cases that ladies have actually stayed that long without being able to conceive. So that's an important thing that usually we try to counsel you when you're trying to pick a method of contraceptive, to know that very rarely you may then have that delay in return to fertility. There's someone raising their hand. I'm not seeing who's raising their hand. Sorry, I can't see. Did someone want to say something? Joshua? Okay, I think I'll go on to, mine has asked, is it normal to shed blood after 5 years of menopause? The answer to that is no. It is not normal to shed blood after 5 years of menopause. And so usually we call that post-menopausal bleeding. It falls under what we call abnormal uterine bleeding. And normally you want to immediately get assessed as to why you are bleeding after menopause, because you're not supposed to bleed. And some of the tests that the gynaes would want to look at, immediately want to interrogate your cervix to see if there could be an issue at the level of the cervix, and also to be able to look at the uterus to see if there could be an issue with the uterus that could be causing you to bleed, and also the ovaries as well. So it's not normal to shed blood after 5 years of menopause. After using FP, I think we've answered that. Can abortion block a fallopian tube? Now, that's a question from Anulika. So first of all, abortion can be carried out in various ways. Yeah, this from the medical, where you're given, where one uses pills, to where they now go in surgically. Now, the one thing that can happen, which can affect fallopian tubes if one has had an abortion, is if one got an infection. Okay, so there's sometimes we call them septic abortions. So you can get an infection because of maybe the way the process was carried out. And so if that infection ascends to the tubes, goes up to the level of the tubes, then yes, you can end up with a blocked tube, not necessarily because of the abortion, but because of an infection that ended up causing some inflammation in the tubes. Yeah, any other question I haven't answered? Why is it the majority of women who are at menopause get fibroids? Okay, that's from Jerry. Now the thing about fibroids are a whole big topic on its own, but yes, now fibroids have been seen to, maybe you may associate them more with women who are at the menopausal age because they tend to be more common as ladies continue aging. So you find when ladies are in the fourth decade of life, that's when, or third and fourth decade, that's when you start picking them up. So as they approach menopause, then, they may now start becoming symptomatic. So you can actually have the fibroids from earlier on, but they're not causing any symptoms. By the time you get to your 40s, then you start seeing that the fibroids have grown so big. And so that is when now people will see them in association with a lady who is getting to her menopausal age. But there's no direct connection between menopause and fibroids. And usually when a lady has fibroids towards the end of her reproductive career, when you're headed towards menopause, we actually tell them that by the time we get to menopause, because you won't be producing the normal hormones of the reproductive cycle, the fibroids then tend to stop being an issue. They never cause any bleeding issues, usually at the point that a lady gets to menopause. Now, why is it that most menopausal women are diagnosed with cervical cancer? That's from Maro Amani. Now, the thing about cervical cancer, what's important to understand is that it's a disease that manifests itself slowly. So what happens first is most sexually active people are exposed to a virus known as HPV. So HPV, your body usually tends to clear that infection in most people. However, in some people, the infection persists and it starts causing changes slowly over time. So usually from the time that one gets an HPV infection to the point that it has caused significant changes in the cells of the cervix, it's 15 years or more. So you tend to see that women who are getting to their 50s again are the ones who now would start presenting with symptoms of cervical cancer, because unfortunately, when this HPV is causing changes to your cervix, you don't have any symptoms. You're absolutely normal. So you go about life normally, and then one day when you hit your menopause, you start having abnormal bleeding. If you weren't doing your pap smears, then you come in and the gynae tells you that there's a growth in the cervix, which has not just started recently. So how to prevent this is to definitely get screened for cancer. There's the pap smears, there's a via Villis. Nowadays, we also do HPV, high risk type testing. So those are some of the things that people can do to prevent such an outcome. So some ladies claim that they got pregnant and had no clue because they had their regular period. How is this even possible? Okay, thank you, Wendy, for that question. Now, what happens to some ladies and in pregnancies? You could get pregnant, but you could also get early pregnancy bleeding. So you could experience a bleed in the first weeks of your pregnancy, and you assumed that it was a period, okay? And so you thought that you were not pregnant. Some people continue spotting even during pregnancy, and they assume that that could be a period. So maybe that could be what has happened, but usually during pregnancy, it is your periods go away. You do not see blood unless there's something abnormal going on. So actually any bleeding in pregnancy is something to be interrogated. So Lynette asks, what's normally the issue when one has an abortion and after a month still tests positive for pregnancy? So thank you for that question. I see we are, okay, we're moving further away from fertility, but still we'll answer it. So normally for a pregnancy, normally what we test with the pregnancy test is the hormone of pregnancy, and it's called beta HCG. So normally it's present in your blood and it passes down through your urine, and we test that in the urine. So we normally say from the time that a lady was pregnant to the point whereby it turns negative, it could even take up to 6 weeks, right? However, if the test is still positive, and maybe a lady is also experiencing some excessive bleeding, sometimes you could have what is called an abnormal type of pregnancy, a molar pregnancy. And then again, sometimes maybe one had an abortion, depending whether they knew that the pregnancy was in the uterus, maybe they went and they did a procedure for that, and maybe the pregnancy was in the tubes. So we still have a persistent pregnancy somewhere, yeah? And even sometimes the methods that are used for abortion, they fail. So there could still be a pregnancy in the body. So if one tests positive for pregnancy after they've had an abortion, it is important to just be seen by a gynae, have a scan done, have an assessment of the pregnancy hormone done in the blood to see what could be going on. Now, some start shedding brown discharge during menopause and it makes them produce unpleasant smell. Is that normal? No, mine, that is not normal. Brown discharge that you're describing could be an altered form of blood. And the fact that you're speaking about it having a bad smell, then that shows maybe an infective cause. So that is someone who definitely needs to be assessed, probably have a pap smear done as well as an ultrasound just to see what could be going on. And what causes the brown discharge? I think we have answered that. Could be, it's a type of bleeding, yeah? So that is, so I have a question about the fertility window. When one uses an emergency pill during the ovulation period, how does it affect fertility? Okay, so when you use the emergency pill, basically you're trying to prevent fertilization from taking place or implantation from taking place. It's a very high dose of a hormone, of basically the hormones that are in. So the different types of the emergency pills. So some just have only the progesterone, and then there's some which have both the estrogen and the progesterone. Okay, so for you for it to say how it affects fertility, it prevents fertilization from taking place. That's basically what it does, right? But it doesn't have like a permanent effect on your fertility, if that's what you're trying to ask. Yeah, it doesn't. Now, what causes prostate cancer? Wow, Josh. Okay, fine. So prostate cancer is a cancer that affects the prostate gland. And it's something that there are several risk factors. So it's something that happens in the black race, in people who, if you have a family history of that type of cancer, then you could be at risk for it. So basically, there's a genetic risk to getting prostate cancer. And I think also the other thing to note about it is that it sometimes can just, it's a cancer that can, and most cancers do that, they are usually in hiding for a period of time. So it's usually significant for men who are above the age of 40 to have a prostate-specific antigen test done, which is something that's one of the markers that are used to see if your prostate is functioning normally or if the levels are abnormally high. Yeah. So why is it that some family planning methods make a woman infertile for a certain period despite the fact that they can ovulate? Does it mean it affects the progesterone hormone? This is from Joyce. Does it mean it affects the progesterone hormone? I'm sure I'm understanding what you're saying, but when you use a family planning method, you are preventing conception. So you're not making yourself infertile, but you're just preventing conception from taking place. So there are the hormonal methods, which I think Dr. Swale spoke about really well in her talk. And then there's the non-hormonal as well. So basically with the hormonal methods, what they do is they prevent you from ovulating. And then they also work to increase the, a plug in the that's what progesterone does. It causes a mucus, thick mucus to be at the level of the cervix to prevent sperm from getting in, and it also causes the lining of the uterus to be thin. So that's how they work. So they don't cause you to be infertile. What they do is just they prevent ovulation. And so the moment you stop using that method, then your hormones will then, your natural hormones will kick in, because this is an artificial hormone that you're putting in your body at that time to prevent yourself from conceiving. So once you stop using the method, then ideally you should be able to go back to your normal ovulation. And yeah, so who else is asking a question? When one uses emergency pill during ovulation, how does it affect ovulation? I think we've answered that already. So usually the effect is to basically prevent you from basically fertilization from taking place, or to delay the ovulation, right? Now, what can cause sperms to be infertile? That's from Josh. So usually, I think we mentioned a bit of the things that can affect men's sperms. So again, we said if a man is smoking excessively, it reduces the quantity of the sperm that you're taking, as well as taking lots of alcohol. If a man has ever had any surgeries to the groin region, you can have issues with now your production of sperms. If you've ever had treatment for any cancer, you've had chemotherapy or radiotherapy, then you can have an issue with the sperms. Or if you've ever had significantly viral infections which have caused you've gotten what we call orchitis, basically, that can also affect your sperm quality and production. Yeah. Thank you, Josephine, for that. You said you've learned a lot, and thank you for the information. Okay. I think we've tried to answer most of the questions. If I haven't answered your question, maybe you can just post it again. I'm trying to scroll through to see if there's anyone I missed. I used to know. I think we have answered it. Okay, there's something from Odhiambo Gabriel. I think I missed this one. He's asked, is there a way a couple may control what gender the unborn baby is? If you can be able to establish what gender. So normally what we say, it's a 50-50 chance, because you're either getting for the sperm, it's either XX, which is a girl, or an XY. So it's literally a 50-50 chance. The only way that one can be able to control is, again, with the assisted reproductive techniques, because usually when they do the IVF, they're able to pick specific gametes, and so they can be able to tell from an early stage whether it's male or it's female. That would be the only sure way to know what gender the baby will be. There are several calculators that you'll see. Some people say it works for them, some people say it doesn't work for them, but you can imagine if it's something that's 50-50, it could work for you, and for the next person, it doesn't work. So literally, to be 100% sure, the only known way is assisted reproductive technique, which has its own ethical issues using that for gender. So yes, I think, is there any other question? Do men reach menopause? It's a good one. And is there an age limit for them? Yeah. Who's raising their hand? I'm not seeing them, but they can go ahead and ask a question.
I'm seeing somebody's raising their hands. I got Claire.
Yes. Go ahead.
Claire is having a question.
Yes, Claire, you can go ahead. Does she want to ask? Claire, do you want to ask it, or I'm trying to? Okay. Claire, where are you? Let me unmute you. There we go. Claire, are you able to unmute? I'm trying to unmute you on my end, and it's not. Katile, are you able to allow Claire to ask a question?
I have asked her to unmute.
Yeah, I'm trying to unmute on my end.
Maybe she.
It's okay. Let's just proceed. When she comes back, then she will ask.
Okay, fine. So let me see. I think I saw something about, there's one who asked about, let's see, men having menopause. So there's actually a phase that men go through that is called the andropause. It's what is thought to be the equivalent of the female menopause, because they also undergo changes in the levels of their sexual reproductive hormones. However, they are not as significant changes as those that the women have, and it takes place very slowly. Men are able to produce semen. It's been shown even, up to their 90s, 100s. People have done studies, and we've seen these men are still producing semen. But the one thing that has been noted, sperm, is that the quality and the quantity of the sperm does reduce as they age. There's no specific time again when they get out their 60s, that's when it starts to go into the andropause, sorry. Yeah, and that's when they get to experience things like decreased libido, maybe they get erectile dysfunction, usually at that point in time. So another question, let's see. Okay, now that sperms are produced every 90 days, does it mean conception can never be achieved in between the 90 days interval? That is from Odhiambo. No, that's not what it means. So what basically it means is that every 3 months, a new batch of sperm is being produced. So even as we're doing the investigations, right? As we wait for those other 3 months to come by, then you find that sometimes some people actually just conceive spontaneously and we don't even need to repeat the semen analysis. However, in some cases, we repeat and we find that there's still an issue. And then even during that time, after doing the first semen analysis, there are usually some micronutrients that have been shown to significantly improve in sperm transport. So it depends on what anomaly is seen on the semen analysis so that we can be able to then now treat. That was so educative, Doc. Thank you, Anne. Does hormonal replacement therapy have side effects? Thank you for that question, Atola. It's a good one. So hormonal replacement therapy usually has been, in fact, the people who feared using it for a number of years and a number of reasons, because mainly it was being something that was being used on menopausal women, that you're replacing a hormone that now has diminished naturally. And so there are women who are being seen to get increased risk of heart disease, strokes, and breast cancer issues. However, those are women who have undergone menopause naturally. When studies have been done to look at women who have undergone premature menopause, it's been shown that they're not getting these similar side effects. And so it's actually recommended for them to, when the benefit versus the risks have been weighed, it's recommended for you to give a lady who's undergoing premature menopause hormonal replacement up to the age when she would have undergone menopause naturally, so that you can help protect her heart, help protect her bones, and basically just give her better quality of life in terms of mental health and sexual health. Now, here we go. Is there any non-medical approaches that could help one to get pregnant? And when you speak of non-medical approaches, it depends again on what the issue is, Mercy. So if you're talking about non-medical approaches, yes, there's lifestyle changes. So, I mean, living a healthy life, avoiding taking too much alcohol, caffeine, smoking cigarettes, maintaining a healthy BMI. So that means eating healthy and also exercising. Those are natural approaches to now you just getting pregnant naturally. And that's what most people are advised in the onset, yeah? Especially if you've just been trying to conceive for less than 12 months and you come in and sometimes you're just anxious. We just tell you, just do this and then let's see if that works. And for most people, it does work. Now, hi, can men's fertility be affected when one rides a bicycle for a long time or wearing tight clothes? Good question, Judy. There's actually some studies which have been done on border riders. And what was being looked at is in comparison to their counterparts who do not ride bicycles, and even people who are exposed to a lot of energy or engine energy, like truck drivers who are constantly next to an engine, or the engine is kind of underneath their groin. They've been shown to actually have changes in their semen quantity and quality. So about wearing of the tight clothes, I've not come across that. But for sure, riding of bicycles for significant periods of time, a daily kind of activity for long periods of time, and then also being exposed to high heat energy, that definitely has been shown to have an impact on the semen quality. But again, as I said, every 90 days, they produce new sperm. So there are those who have been seen, once they stopped doing these activities, again, sperm quality goes back up. Yes. Good. Connie Kaimeni. thank you first. And it says, my question is, why is caffeine intake a risk factor to infertility? Okay, so this is really very debatable in several forums, yeah. But the main thing that caffeine has been, and it's significant caffeine intake. They say 200 milligrams per day. Above that has been shown to be associated with delay in getting pregnant. Okay, so the direct link is not known. So what they did is just looked at women who are taking this caffeine at this level and those who are not taking, who are comparable on all ends. And it was seen that these ones who are taking significant levels of caffeine were not getting pregnant. So it's thought that maybe it has some form of toxin effect again on the likelihood. You know, you need a good friendly environment to get good quality eggs. So that's what it's thought to affect. So yes. And again, for ladies getting pregnant, caffeine has significantly also been shown to cause an increased risk of having miscarriages in the first 12 weeks of the pregnancy. So that's usually also another thing. So even during pregnancy, we tell ladies, if you can avoid to take your coffee those first 12 weeks, then avoid it. Then yes, if you must take it, then you can take it after that. Okay, thank you so much. The content was okay. Is surrogacy being practiced in our country, and can a woman who is already in their menopause be a surrogate mother? That is from Mine Gashao. Thank you, Mine, for that question. And yes, surrogacy is being practiced in our country, and usually the best candidate, again, to be so theoretically, and yes, it's a lady who is in her menopause can be able to be a surrogate, but if we're looking for a surrogate, usually you're trying to get someone who is healthy on most ends. By the time we're getting to menopause, we find that lifestyle diseases have started creeping in. Some people have hypertension, some people have diabetes. So we wouldn't want to be looking for that as a candidate to be the surrogate, but theoretically, yes, someone who has achieved menopause, they would have to, of course, undergo lots of hormonal stimulations, but they can be able to be a surrogate for someone. And surrogacy is practiced, so one just needs to find a fertility specialist and then they offer them that advice. Okay, thank you, Sheila, for your comment. You say you have learned a lot. And also Christabel, who says it's been such an educative session. Thank you so much. Right. I don't know if, Katila, you managed to get through to someone who was raising their hands. I don't know. Anyone who had any other questions? So here we are in the chat. Does over-exercising? Oh, yes. Yes, Katila, you're saying?
There's a question in the chat.
Yes, I've seen it. The one from Esther Kuna. You're asking if over-exercising really causes infertility. Thanks for this question, Esther. I tried to clarify that when I was discussing it. And basically what I was saying is it's excessive, you know, to the level of athletes, right? So what happens is your body basically operates on hormonal axis. And so when you do extreme exercising, then actually what you notice is that the hormones now change in terms of the way they're relayed from your brain all the way to now your ovaries. And most ladies who are doing extreme exercises tend not to get a period, okay? Again, it's something that is transient. So the moment one goes back to normal level of activities, then your hormonal axis goes back to normal, and ideally one can be able to get pregnant. So it's not a function of like saying that you exercise 5 days a week. No, but there's that extreme competitive sport exercise, and we've seen lots of athletic ladies who just sometimes have to take time off from work to literally be able to get pregnant. Yeah. So let's see if there's another question. I think is so Atola is asking who or what is a surrogate? Yes, thank you for that, because I don't think I had mentioned what a surrogate is. So basically, when you want to get, normally pregnancy, a lady carries her own pregnancy, but sometimes due to certain reasons, a lady may not be able to carry her own pregnancy. So at that point in time, then another lady can be able to carry a pregnancy for lady A. So let's say one lady wants to get pregnant, but maybe because of certain reasons, she's not able to get pregnant, then she identifies, or basically the fertility center identifies someone who is willing to carry a pregnancy. So in that case, normally they can take the eggs from the first lady who's trying to get pregnant and the sperm from her partner, and these are usually fertilized in a lab, okay? Now, once that happens, this is then introduced into the lady who is carrying the pregnancy, who is the surrogate, okay? Yeah, so that's what a surrogate is. Now, how does emergency pill affect my body if I use it more than thrice within a short period of time? Eunice, so what that does, it throws your body into a hormonal storm, basically. That's what it does, because it's a high level of a hormone that we're taking for the purposes of trying not to get pregnant. So you really then throw your hormonal axis all over, and you'll notice that the periods will tend to become really, really irregular. So what we usually say is, if you're finding that you're having to use this pill more than 4 times in a year, every 3 months, then you likely need a more stable form of contraceptive. Yeah, even if the points in which you need that emergency contraceptive are just within 1 month, it is not advisable for you to use the pill that frequently. Yeah, so I think that's what it is about the emergency pill. Is there anything else? Why does one experience discharge of white like substance when periods are near and after? That is from Wanjiko Hilda. Thanks for that question, Wanjiko. Okay, now the hormones that control the menstrual cycle are also responsible for the changes that take place in the type of cervical, basically vaginal discharge that you will get, okay? And remember, we mentioned that at the time that you are ovulating, that's usually 14 days before you get your period, then the discharge becomes increased in amount, it becomes more slippery, and it's a bit thicker at that time. Now, once you are getting, when your periods are about to come, in the main hormone that is there is called the progesterone hormone. And that hormone is the one that is responsible for this kind of discharge that Wanjiko is describing. So usually once your periods are approaching, you tend to have that white colored discharge again. And then now, once they are over, the discharge now goes away, and you start a whole other cycle. So yeah, the most important thing I'd say, Wanjiko, about discharge is just knowing what's an important discharge. So you need to know that normal discharges are usually either clear or they are white. They don't smell, and they're not associated with any other symptoms such as itching, such as soreness, or any form of irregular cycle. So if you're having a discharge that falls within that category, then that's a normal discharge, and that's not something that should worry you, okay? And so we have a question, I think still, in case Lady A, who cannot carry the pregnancy, is HIV positive and has Lady B, who is willing to be her surrogate mother, will it be safe for Lady B not to contract HIV during the process? That's a good question. That's again from mine. Okay. Now, usually, that's a very unique scenario, okay? But usually when we are doing this sort of, if it was such a setting, then there's usually use of what is called PrEP pills, basically what you call the pre-exposure prophylaxis. So those are something that may be used in such a setup if fertilization was to take place in this setting, so that to just protect the rights of also the second lady. That's what I'd say. But again, they may be able to just do a matching process where they would find people who are both having the infection, be able to, one lady B would be probably a better candidate if they are both on that end with the infection. But again, in our current setting, if someone has extremely low viral loads, then transmission of an infection is also very, very rare. Yeah. Why does one? How does? Is it true that a foul fishy smell can be caused by semen altering the normal pH of the vagina? Okay, that's from Wendy. Now, the most common thing that people describe semen to smell like is they say it smells like jik. So it does have a unique smell to it, right? But when it doesn't alter the normal pH of the vagina has its normal environment, which is caused by certain bacteria. And so their work is to basically maintain that pH in the vagina, right? So semen would not change that, because of, if you have the normal bacteria still present in there, they'll be able to regulate the pH to go back to normal. If someone is, however, having a foul or what you're describing as a fishy smell, that could be a sign of an infection, right? And they may just be experiencing it or noticing it more when they're intimate with their partner. So it would be advisable that if someone is having a fishy smell, in fact, that's really commonly associated with a condition known as bacterial vaginosis. So it would be good to just be seen by a gynecologist, and they'd be able to assess you and put someone on the right treatment. Any other questions? Thank you, Mine. So, hi, Doctor. During menses, is it normal to have pimples either during menses or after? And can you shed some light on depression during menses? Oh, wow. Thanks, Wangari, for that question. So I think I mentioned briefly about what we call molimina. That's a medical term for what you're trying to describe, or sometimes we just call it the premenstrual syndrome. So because of the hormonal changes in your body, they do affect your mental health, they affect your level of energy, and so your moods as well are affected, yeah? So the pimples are also part of what is experienced by some women as their periods are about to come because of the hormonal changes that the body is going through. So if someone is having extreme symptoms, it's actually a condition that we do treat, right? Extreme premenstrual syndrome. Basically, it's called dysmorphism. But if you have that, if you're experiencing dysphoria, if you're experiencing that kind of low moods and depression, especially associated with the time of your periods, then you may need to see a gynae. And we have found that some things that help usually are a lot is exercising and eating right and just making sure that you hydrate well. And if that fails, then in some women, in extreme cases, we do have to put them on medication to prevent them from ovulating. And these are usually the contraceptive pills. But we notice that when we put them on that, then they stop experiencing these extreme premenstrual syndrome symptoms. Thank you, Wendy. You say you've learned quite a lot today. You're very welcome. And then I think someone has asked, does a woman who has reached menopause get the discharges? Good question from Swalha. So most of the time, you may get minimal discharge because, again, the hormones that are responsible for regulating your menstrual cycle and for causing you to ovulate have gone, the estrogen, the significant one, has gone down. And it's what usually causes the vagina to be basically moist and even the cervix to produce the discharge. So most women will actually report a lot of vaginal dryness once they hit menopause. And that is something significant because it can actually cause a lot of sexual dysfunction issues. So normally we can also treat that. We usually use sometimes estrogen creams, we give them that, or we advise them to use water-based lubricants when they are having sex. Again, they have to be very careful because now if the vagina is dry, then they're also at increased risk of getting now just inflammation, even just from having sex. So yes, they do get, the discharge will be minimal. Most women report no discharge during menopause. So kindly talk about hot flashes during menopause, and is it something associated with bipolar or something related to that? So thanks for that question again, Wangari. And the hot flashes basically they're called vasomotor symptoms. And what happens is because you have lost the estrogen, again, that's when now you just break into these sweats. So all these are just, it's kind of like a withdrawal, like the way someone can be, I think of it like you're addicted to a drug and you use the drug daily and then you're not using, it's not there. So this is how your body responds when estrogen is taken away from it. The hot flashes are now one of those symptoms. Yeah. Thanks, Bala. You said it's a great session. Thank you very much. So I hope that answers that on the hot flashes. And no, it's not associated with bipolar. Bipolar is one of mental illnesses. And so it's a mood disorder. So the hot flashes are not associated with that. Not that something that I've come across though. Yeah. Could you elaborate more on erectile dysfunction and infertility in a man? And also, if a man has had a vasectomy, can it reverse itself naturally? Okay, so when you talk of erectile dysfunction, basically we're talking about failure to erect, just breaking down the word. So it means that a man is not able to, because erection is part of the sexual cycle. So usually if everything is okay, when one is sexually excited, they should be able to get an erection and maintain an erection for sexual purposes. So if a man is failing to do that, then that's when we come up with the term erectile dysfunction, okay? And it can be due to several factors. We only touched a bit on hormonal today, but I mean, it's been shown to also have a very significant mental bit to it. So if someone is also under a lot of stress, if someone is using certain drugs, if someone has certain medical conditions, then they can have the erectile dysfunction, okay? And so how it would cause infertility is that the man would not be able to, the sexual act would not be able to happen. And so depositing of this sperm is quite significant in the vagina for a lady to get pregnant, right? Then if a man has had a vasectomy, can it reverse itself naturally? I think what you're trying to ask about is whether there can be failure of a vasectomy. And yes, it can, but very, very rarely. So there's, and also as well, vasectomies are reversible, yeah? So, but now the one usually needs a surgical procedure. But what can happen is that someone can have a vasectomy and yes, there can be failure of the procedure and the man could still be able to produce some sperm when he's ejaculating, because the goal is usually to prevent that. Yeah. Anyone else with a question? Are we finished on that, I think? Okay. There's something in the chat, let's see. Someone has asked if the family planning methods can be the reason as to why most women keep having recurring vaginal infections. Okay, so that's an interesting question. So the family planning methods are several, which were discussed on Thursday. The one that has been associated with recurrent vaginal infection is when you have an intrauterine device placed. right? So if you have the IUCD, that's a copper device inside the uterus, how it works basically is it causes a lot of inflammation. Inflammation is basically, if you can think about something that's causing the, it's something, it's chemicals, let me put it that way. Chemicals are produced by the coil, which prevent a sperm, which kill the sperm when they try to get to the eggs. So in that environment, because it's very, very inflammatory, then if an infection gets in there, it can be able to really thrive. And that can cause ladies to get recurrent vaginal infections. So the one method that, it's not that it causes you to get the vaginal infections because you have the coil in there. But however, if you have it in there and you get an infection and it's not well treated, then you can keep having the infection coming back and forth. And then again, some things that we call recurrent vaginal infections, we need to know what type of infection it is specifically. Is it non-sexually transmitted or is it sexually transmitted? Because sometimes if it's something that's sexually transmitted and the partner is not being treated, then the lady would definitely keep getting recurrent vaginal infections. So that's also important to mention that, yeah. Thanks, Atola. You say you're enjoying the session. And Kizito says, is it possible for a man not to release while having sex? And what causes this? Okay, so there's something called dry ejaculations. And that means that he's actually getting the point of ejaculation, but there's no ejaculate coming out. So basically the semen is not coming out. And so that usually is something that can occur if there's maybe an issue with the male reproductive tract system, the one that brings ejaculate to the urethra. So that's something that would need to be assessed. But yes, it does exist, mine. It is something that's there. Is someone who has unmuted? I don't know if we're able to mute them, because I don't know if you can all hear me. There's a lot of background noise. Okay, thank you. Let's see, there's another question in the chat. Let's see. Sorry. And so, what could be some causes of foul smell from the vagina that has been for a long time? That is from Lavin. So ideally, when you have first of all, the first thing to note is that the vagina has a natural environment that is maintained by certain bacteria, which we call good bacteria, okay? And so depending on the time of your cycle, there would be a discharge. The discharge doesn't necessarily smell so great. It has its own smell, which is not foul, however, okay? So that is the first thing to note. But if someone has a foul smell that's coming from the vagina, that is really a sign of infection. So that is something that needs to be attended to. And the different types of infection, as I mentioned earlier, it could be something that is basically sexually transmitted, something that's not sexually transmitted. So again, that would be very difficult to pinpoint at this point, but it's something that needs to be assessed. And from there now, you can be able to be tested. So usually, once you're seen by a gynae, there's some times you can see a discharge and we're able to diagnose immediately this could be this. But there's some that we do tests for, so we can be able to carry out a vaginal swab, whereby you pick the sample and it's taken to the lab, and one can determine is there something infective in there that's causing you to get that offensive smell. Okay. What could be the causes of brown discharge immediately after menses? They may go for a week. Is it all about hormonal imbalance or is it an infection? Okay, so when we see a brown discharge, so blood, normally during the cycle, you notice that for most people, the blood could change in color, even on the days of receiving the period, right? So some days it's really bright red, some days you see some black clots, sometimes you see something brown. And so usually as one tends to get to the end of their cycle, then you may notice that you can still be having a bit of brown discharge. That is just an altered form of blood, okay? So blood which has been in the cervix and the vaginal canal for long, then usually can come out like that. So it wouldn't be something that is worrisome if it's coming right after your period. However, and sometimes it can also occur if someone is also using a contraceptive method, so that could also prolong such a discharge from being there. So, I mean, could prolong a discharge in terms of its stay. But if you're seeing that you're having it for more than 1 week and it's something that's concerning, it would be good to just be seen by a gynae as well, just so it can assess the cervix and make sure that there's nothing abnormal going on. Can masturbation cause erectile dysfunction of a man? Well, that is interesting question, but yes, it can, because what happens is if one is used to overstimulating the penis themselves, then sometimes just getting a natural erection now becomes something difficult for them to do, okay? Or even maintaining the erection, because they have overly stimulated the penis. So usually in such cases, usually start by telling them to try and reduce on the masturbation and maybe use a condom to reduce the sensitivity so they can maybe be able to maintain an erection for longer. Then such a person can also benefit from seeing a urologist as well. Is it true that sperms can stay in the uterus for up to 3 days? That is correct. And that is why we have that fertility window whereby we say that you can be able to get pregnant even if you have sex, even up to the 5 days prior to your fertile day, because the sperm can usually survive inside the reproductive tract for that long. So that is a true statement, Cherop. Right. Any other questions? Someone is looking for a transcript. And someone is asking if is family planning a major cause of vaginal infection? No, family planning is not a major cause of vaginal infection. I think we've gone through that as we talked about the IUCD and the risk of someone having an infection recurring if it persists when they have an IUCD in there. But family planning in itself does not cause you to be at risk of getting vaginal infections, no. Now, someone is asking about, where are we going? What are some of the side effects of different family planning methods? Wow, okay, fine. I think we had a session on this on Thursday. Basically, the one thing I think the take-home message about family planning is all of them can cause side effects. However, you are not guaranteed to get a side effect. You may use a method and it doesn't cause you any side effects. The hormonal types of family planning methods usually can cause irregularities in your bleeding. So you can have bleeding at a time of your cycle when you're not expecting to bleed. They can cause issues with your face. Some people get acne. They can cause headaches. They can cause you to get weight changes. Some people report weight loss. Some people report weight gain. Some of them can cause mood changes. So there are people who report lots of mood swings with some of the hormonal methods. And then there are those who also report changes in the sex drive. There are several side effects, but those are some of the major ones to highlight about the hormonal ones. And then when you go to the non-hormonal, which is now the coil, there are those people who report that they get heavier periods with the copper coil. There are those who report that they get more painful periods with the copper coil. There's the Mirena, which is also a type of coil, but it has a hormone in it. And by and large, most people who use that method don't report many side effects. However, for some ladies, again, as I said, irregularities in the bleeding. So you may notice that some women don't get a period at all. and or they just get light spotting. And then some people tend to get some migraines, others get issues with their breast, they can get tenderness with their breast, but most of the time, these symptoms tend to settle in the first 6 months of using a method. So I think that's what I'll say, but there is the session with Dr. Swabra Swale, and she really tackled this topic well. So you can always check in the group, the Facebook group, and I think you can be able to get more answers about the different family planning methods as well. And so someone has asked if it's costly to see a gynae at a level 5 hospital. So that is a government hospital, and so usually there's always a registration fee. But I think with NHIF, if one has NHIF, then one can be able to access these services without having to pay too much. And for the government hospitals, they usually the services tend to be at least subsidized. So costly is relative. Of course, seeing as gynae is more expensive than seeing the general doctor or the clinician, but at least it's a good fit because it can be a bit more pocket friendly. So someone says they're enjoying the session. That's Jacqueline, thank you. And Katila, I think someone wants to see that attendance list. Please help George out. And then someone is asking about endometriosis, and then also asking about safe days and whether it's normal to have irregular periods twice in a month, like a week, and then they skip a week, and then they come back. Okay, so this is a very packed question, Wangari. Okay, fine. So I think there's also a session on endometriosis, and a lot of there was a lot that was also discussed from that, so that can also be gotten from the group. But I think I'll just mention about endometriosis and fertility. So basically with endometriosis, what you are experiencing is the tissue that usually is inside the uterus, lining the uterus. The one that we mentioned is usually shed together with the egg at the time of once one has ovulated and they've not gotten pregnant, what's shed together. So that tissue that's supposed to come out through the vagina instead finds its way into the pelvis. So usually it's thought it travels up through the tubes, or maybe it goes to the bloodstream, but it finds its way into the pelvis, okay? And once it's there, it starts causing symptoms of inflammation, and it can cause you to get scar tissue, basically what we call adhesions. Adhesions is scar tissue that is basically joining or matting organs and tissues together. So with endometriosis, because of that, and also because of the inflammation, and also it's been shown that some women, because of this inflammation, they do not ovulate, then they can tend to be infertile. So, however, it's important to note that there are also a good number of women who have endometriosis who do get pregnant, and they get pregnant naturally, and the endometriosis is maybe diagnosed later on in life. And, so with endometriosis, it really varies from one individual to the other, and even the severity of symptoms and severity of disease also varies, right? So you mentioned about the safe days, and I think I'll take us back to the point where we talked about the fertile window, and basically we said usually you ovulate 14 days before you get your period, and so the day of ovulation and the 5 days before that are usually your fertile window. So the rest of the cycle ideally would be your safe days, right? And I think it's in the slides. I'm going to share the slides with Katila, so you should also be able to access them. And more importantly, you can also be able to download an app, Wangari, on your phone, which, as long as you put in your period for at least about 3 months, it's able to pick up a pattern and show you when your fertile days are, when your safe days are, okay? Now, that works if you have a regular cycle, okay? Now, the other question I think was about irregular periods. If you're having a period like twice a month, they skip 1 week and then they come back later. If you have a short cycle, if you have a cycle that's 21 days, you can see your period twice in a month. That would maybe at the beginning of the month and at the end of the month, right? However, if anything more than that is happening, you have periods for 1 week and then another week you're seeing that is abnormal bleeding, and there could be several causes for that. So that would just need to be interrogated and evaluated separately. Okay. I think you said if someone can be addicted to masturbation, can they see an expert? And you say a urologist. Okay, I think I'll type out the name of the specialist who helps with. We work with in terms of, so it's called a urologist. Trying to type that in the chat. Let's see. But basically, in terms of someone who is having addiction to masturbation, then that's someone who needs to be seen by a therapist. Yeah, so a behavioral change therapist. Counseling goes a long way in terms of helping one. So it's an addiction like any other addiction. So basically, it's something that can be sorted out by establishing what is the cause of the addiction. Why is one addicted to this habit? And from there, now dealing on the why and hoping to stop the addiction itself. So yes. So I've typed it in the chat, the name of the urologist. That's a specialist, a urologist. And then how, and someone has mentioned about the flow up. Yes, the flow up is there. It's good for predicting, yeah, your safe days. So that's a good one. Now Josh is asking, how can you have an irregular cycle and how can you make it regular? I think we spoke about this as well during the presentation. And basically, if you're having an irregular cycle, that means that likely you are not ovulating, okay? And so what needs to happen is I need to establish why you're not ovulating. And so once that is established, then you can work from there to see whether you can make it regular. One of the common things that people are given is the usual family planning pills to try and regulate the cycle, but it's not advisable to just use them without knowing what the cause of the irregularity is. So the best thing to do is to seek a consult from a gynecologist, and then you can be able to establish what exactly is the cause of this irregular cycle, right? Use of e-pills can also make periods irregular. That is very true. I think we talked about the e-pill, and I told you just basically throws your body into a hormonal storm. And so, yeah, your periods just are wondering, when am I supposed to come? And so they can just start, you can just have irregular bleeding throughout, or you also go for gaps without seeing the period. So is it costly to see a gynae? I think we've mentioned this, Naveen. I am not sure of the exact figures, but it should be within an affordable range. I think below 1,000 shillings, possibly, of about 500 there. So yes. Any other questions? I think there was someone who had raised their hand. Did we get back to them, Katila, or they left?
I guess she left.
Okay, fine.
Yeah.
All right. Thank you. I think we've covered quite a lot in terms of fertility and others. So okay, thank you. I think most of the questions are covered. I'm going to share the presentation with Katila. And then as well, I'm seeing there's so many questions that people have. You can always feel free to send them on my Instagram handle. I'm going to share that in the chat as well, so that maybe I can be able to address some of those issues in some of the talks that I usually give. So I'm typing that in the post as well. But yeah, I think that is it for tonight, Katila. What do you think?
Thank you so much, Dr. Lee, for that wonderful session. Actually, I didn't think there could be many questions on fertility, and I've really learned a lot from the members and also from you. I'm so glad, and actually, I saw even in our live page that the participants are saying that they have learned a lot, and I also
Oh.
shared the experience from the life. They really
Mm.
said it was a good session. So thank you so much, Daktari, for that session. Maybe as Daktari has said, maybe if you have a question on fertility that maybe you didn't.
Cannot hear you, please. Please, Katila, be audible.
Maybe if you didn't get your question answered by Daktari, you can always ask her on our Instagram page, or maybe she can. For those who want to consult, also you can try out to reach to us so that she can help you on maybe the problem that you think is so personal and you don't want to share it in the group.
Yeah.
Yeah.
All right. Thank you so much, everyone, for being present and for being active participants. You know, when you're behind this microphone, sometimes it's like you're talking to yourself. So at least when people send in the questions, you know that they're interacting. I think it was a very enjoyable session, and I will definitely share the slides with Katile so that you people can benefit from that. And I think we'll be having another talk with you guys on the 21st about cesarean sections. So you can also prepare your questions for that. I received some of the questions that you had in advance, but nonetheless, you can always prepare for that session. I'm looking forward to that as well. Thank you. I think people are now free to leave. Thank you.
Thank you so much, Daktari, and have a good evening. I know we'll interact more. And for the participants, thank you so much for attending the session.
All right. Good night, everyone.
Thank you.